Thank you for joining us. If you could double check your audio and video.
Good afternoon. Can you hear me?
Sure can. Thank you so much.
Can you see me yet?
I need to get to the right spot in my screen here.
Oh, it probably would help if I uncovered the camera. My apologies.
Oh, I see. Thank you so much. To our commission members, the public live stream will be starting momentarily. Please, during the commission meeting, keep your video on to show yourself as a voting member of the commission, and please remain muted unless you are speaking. Thank you so much. We will be getting started momentarily. For those commission members who have joined and not yet checked your audio and video, feel free to do so now.
Hey, it's Jim Nossett. Can you hear me okay and see me?
I sure can. Thank you so much.
Thanks.
Okay. Good afternoon, everybody, and welcome to the meeting of the Indiana Behavioral Health Commission. I'd like to welcome all the commission members as well as everybody watching on the live stream. We have a full agenda today, so we're going to jump right into it. Just as a reminder, the meeting is being live streamed on YouTube, and the link is available on the Indiana Behavioral Health Commission website. for public access and viewing as well. And then also the public questions. So if anybody's watching at home and have questions they want to share, you can submit them to the Indiana Behavioral Health Commission email address, which has been put up on the screen there. So I'll give folks a second to note that down, and we'll try to periodically share this screen again so folks can take note of it if they have questions. So I should probably introduce myself. My name is Jay Chaudhary. I'm the director of the Indiana Division of Mental Health and Addiction, as well as the chair of the Indiana Behavioral Health Commission. So since this is only our third time together, I thought we would just go around really quickly and introduce all the members. Again, just sort of your name and your title, and then we can jump right into the agenda. I'll just call people out. Barbara Scott. Oh, we can't hear you, Barb.
Oh, I'm so sorry. Barbara Scott from Aspire, Indiana.
Dr. Nassett.
Hi, Dr. Jim Nassett, emergency physician and EMS physician at Hendricks Regional Health.
Lieutenant Mays.
Lieutenant Tony Mays, Fort Wayne Police Department.
Steve McCaffrey.
Steve McCaffrey, CEO, Mental Health America of Indiana.
All right, Ray Lay. Ray, can't hear you. Okay, we'll come back to Ray. Mimi Gardner.
Mimi Gardner, HealthLink, Chief Behavioral Health and Addiction Officer.
It looks like Ray figured it out. Ray.
Yes, sorry about that, everyone. Ray Lay, owner, SMI Enterprises, Indianapolis, Indiana.
All right, Matt Brooks.
I'm Matt Brooks, President and CEO of the Indiana Council of Community Mental Health Centers.
All right, Dr. Negendank.
Hi, I'm Dr. Christine Negendank. I'm the Chief Medical Officer at Adult and Child Health.
Katie Adams.
I am Katie Adams, President CEO of Southwestern Behavioral Healthcare.
Brooke Lawson.
Hi, I'm Brooke Lawson, Mental Health and School Counseling Coordinator for Hamilton Southeastern Schools.
Rachel Halleck.
Rachel Halleck, Deputy Director and Chief of Staff for the Division of Mental Health and Addiction.
Katrina Norris.
Good afternoon, Katrina Norris, Executive Director, Indiana State Psychiatric Hospital Network.
Sharon Bowman.
Sharon Bowman, Professor and Department Chair, Ball State University, Muncie, Indiana.
Dr. Zaire.
Hello, I'm Ann Zaire. I'm representing Indiana Medicaid. I'm an internist and I work for Indiana Medicaid.
Tim Kelly.
Yeah, this is Tim Kelly. I'm with Community Health Network. I'm the Medical Director of Addiction Treatment Services.
Sheriff Nielsen.
Mike Nielsen, I'm the Sheriff of Boone County. Good afternoon.
Carrie Cadwell.
Hi, Carrie Cadwell, CEO of Fort County.
Leah McGrath.
Hi, I'm past president of Fisher's Youth Assistance Program and here as a parent and community representative.
Donna Cully.
Hi, I'm Dr. Donna Cully. I'm the Director of Child and Family Services at Southwestern Behavioral.
Okay. Guys, did I miss anybody? I think I got everybody on my screen. If I haven't, I'll be quiet for a minute. I think I got everybody. You guys moved around a little bit on my screen, so I want to make sure.
Hey Jay, it's Corey Carey. I am the new Deputy Director of Policy and Division Collaboration with the Division of Mental Health and Addiction.
Of course, Dr. Carey, thank you. Welcome. So those are all the commission members. All right. Well, so moving on, we're going to go ahead and just do a quick overview of our meeting today. Just kind of some context for our meeting. I hope you all had a chance to take a look at the materials that were sent around. You know, we've been at DMHA reflecting quite a bit on the first couple meetings of the commission and kind of the challenges of doing what we're attempting to do in this environment, right? Virtually over Zoom. We don't really know each other, although some of us know each other from other backgrounds. And you know, there's a lot of us here from, I think, a lot of really interesting, exciting backgrounds and relevant backgrounds. And so in the back half of today's meeting, we will be talking about kind of our proposal to accelerate the commission into the action phase. Even though it's only our third meeting and the first one was you know, more of an intro meeting, kind of freaking me out that we are nearing almost a quarter of our time together. So it's time to start, you know, putting down something down on paper and moving forward. So we'll talk more about that towards the back end. You know, and this meeting was initially planned to be kind of an in-depth review of some of the financial considerations underpinning our system. And that, frankly, thinking about that is kind of what prompted us to move into this sort of pivot, because that could be 4 2-hour meetings and we still wouldn't scratch the surface. So, you know, kind of occurred to us that we need to break down into smaller groups and talk more about this in manageable chunks. But we still wanted to touch on a couple financial issues because it's so important. So Dr. Hanslick is here. She's our guest today. So you can say hello if you want.
I am Dr. Maria Hanslick. I'm a clinical psychologist and owner of Integrated Psychological Center of Indiana.
Great. Looks like we have another commission member join. Chase Lyday, do you want to introduce yourself?
Hi, Chase Lyday, Chief of Police for the Avon Community School Corporation Police Department. Really excited to be here.
Okay. Before we get into our substance of our meeting today, we have to take care of a little bit of business. I believe Bethany shared the meeting minutes with everybody via email, and I believe there's a link as well in the chat. So hopefully we got a chance to review them. Does anybody have any comments or discussion on the minutes? Okay, can I get a motion to approve the minutes?
I'll motion to approve.
This is Ray Lay. I'll second it.
All right, everybody in favor, can you please unmute yourself and say aye?
Aye.
Aye.
Anybody opposed? Okay, the motion carries. And so for the record, I forgot to do that last time, so I'm getting better. All we can hope for is continuous improvement, right? So great. So with that, I'm going to so today we're going to talk about a couple different financial things. I'm going to do a really quick overview, and I mean really quick overview of kind of just the general, we're calling it public financing. So, you know, taxpayer dollars, both federal and state. And I'm not going to go into the local because I wanted it to be quick. So I'm going to go into the federal and state, just really quick overview of kind of just what the dollars are, and then lay out a couple of challenges that I see, which is a very incomplete list. And I'm sure many of you can speak much more detailed and eloquently about the challenges caused by kind of the federal and state funding setup. But I thought it was just kind of a nice way to kick this off. And then we're going to kick it over to Maria, who's going to go into some of the ins and outs of the private side of things. One of the challenges for me as the DMHA director, but also the chair of this commission, is kind of constantly remembering that this is not the DMHA commission. This is the Indiana Behavioral Health Commission. And so we wanted to make sure we got a nice dose of the private side of things as well, which is the system that frankly most Hoosiers have to figure out how to navigate. But the you know, considerations and the questions that we're trying to answer at the same time, that is, you know, how does finances and the structure of finances and, you know, lack of enough finances, how does that impact access to behavioral health for most folks in Indiana? And so that's the question I'm just going to touch on, and that Dr. Hanslick is going to dive a little bit more into. When I share my screen, I'll have a short presentation. Feel free to jump in and interrupt. You all know, frankly, more than I do probably about a lot of these things. So Going to attempt to share my screen here. All right, can everybody see that? Okay. See if it'll turn into a slideshow. The spinning wheel of death is what I have here. So hopefully it will load here. Okay, well okay, there we go. All right, so just really quickly, and these are a lot of numbers. This is a terrible slide. I fully recognize it. These are not the type of slides I like to make, but I just thought it would be really important to touch on a couple things. And these are the state appropriations for last state fiscal year 21. Oh, I'm sorry, the current one that we're in. Some of these took a little bit of a hit with COVID. And then as you all know, the budget for the next 2 fiscal years is currently being created and debated in the legislature. So this is very much a snapshot. And just I wanted to highlight a few things here. If you look at this sort of second line, the seriously mentally ill appropriation, that is the biggest single chunk of state money that's appropriated specifically for mental health. And so that's around $90 million. And that actually is a little misleading because that money is almost 100% turned into the state Medicaid match portion of the program called the Medicaid Rehabilitation Option, which is used exclusively by our CMHCs. So that 90 million is actually, because of the way it works, turned into significantly more through that in state and federal money. But as you can see, that's the biggest chunk, and 100% of that goes towards a very specific and important item and line item and type of programming. As far as the rest of that, you'll kind of see there's, for child psych, likewise, a lot of that goes towards, again, the Medicaid match that's paid for what are called psychiatric treatment, PRTFs, I don't remember what they're called right now, but so they're inpatient residential treatment for youth. And so those are kind of like the biggest chunks there. And then I just also wanted to point out that the Forensic Treatment Services Fund, which a lot of you know as Recovery Works, is the other kind of really large chunk there. And that is, those are services that are intended to help folks that are in the criminal justice system access mental health and SUD treatment. Those are kind of some of the highlights. Again, I don't want to necessarily go into the weeds on a lot of this stuff because I think in our subgroups later we will be going into the weeds. I just wanted to give a lot of you all kind of a snapshot of the state funding. And then the other big chunk obviously is our state psychiatric hospitals, which are about $164 million. And they serve just the most severe of cases. Our motto at the hospitals is, we take the hard ones. And so we are there for the cases that have failed all kinds of other options, right? They failed long-acting injectable treatment. They failed community options. And so our goal there is to stabilize and treat folks and kind of get them back in the community as soon as possible, because that's the way the system is set up. So any questions on the state funding? Again, I really just wanted to give a really quick snapshot of that.
Jay, do you have anything on the SOFs or?
Yeah, down there, the state psychiatric hospitals.
Oh, sorry, apologies.
Yeah, so Matt's referring to state operated facilities. We're trying to change that nomenclature in state psychiatric hospitals because we want to emphasize that these are actually hospitals and not kind of like custodial facilities, because that's how they get kind of cutting edge mental health care there, and so they're hospitals. So Matt, you can see 164 million for the hardest of the hard cases. And the reason, part of the reason that is so high, I should mention, is because of a concept called the IMD exclusion, which stands for Institution of Mental Disease, which is a federal rule that doesn't allow any federal money to be used for the vast majority of inpatient psychiatric healthcare. So the state has to cover 100% of the costs for very expensive inpatient psychiatric hospitalization for the vast majority of people. And we can and we will go a little bit more into the state hospitals at a later time. Any other questions on state funding? Okay. So the other big chunk, obviously, when we're taking out the local, because that's just, again, very complicated and convoluted, is the federal funding that we receive at in the state of Indiana. And so on the mental health side, we get the mental health block grant. It's about $12 million every year. The majority of that is kind of passed through to the CMHCs as well, for help with underinsured folks and folks for which reimbursement is not going to happen, as well as some of our other target populations. There's a link there if you want to take a look at that. We've gotten a lot of federal substance use disorder money over the last few years. We get the $32 million block grant, and then we have also gotten over the last few years the kind of archaically named at this point State Opioid Response Grant. This was a federal initiative geared towards combating the opioid epidemic. In the most recent version of this, which has just started federal fiscal year, so in October, we were allowed to use this money for not only opioids but also stimulant use disorders, which was a good change, because I think that we know that, and the folks on this call probably know better than I do, that things like methamphetamine use has not gone away during the opioid crisis. If anything, it's gotten worse. And then we administer about $17 million in other discretionary grants. And then the other big piece of this is the Medicaid claims, which is, again, I'm not going to go into the federal percentages and the financial participation, but there's, it's a state federal program, and there were about $375 million claims for mental health in last year. So just a very, very short list of challenges, and then I think we can see if anybody has any questions on these, and then we can move on. To me, one of the biggest is just kind of a lack of funding streams for key programming. There's a few things, and I'll explain what these acronyms are. So subacute is kind of that step down level after inpatient mental health hospitalization, psychiatric hospitalization. It's a very important stage, and it's one that we just don't really have in a meaningful way in the state. I mean, there's a few that people have made work, but there's not a whole lot of it. ACT stands for assertive community treatment. And these are the treatment modality where a very kind of intensive and assertive, like the name sounds, wraparound programs that wrap people around in the community with enough supports to allow them to stay in the community. Probably not coincidentally, our state hospital numbers have shot up since the ACT program was defunded around 2011, 2012. And so that's probably why you have that there. And PHP stands for partial hospitalization. It's kind of, again, the theme here is, I think, that's in between, not quite say hospital level, but also for folks that need a bit more there. And so that I think the lack of those funding streams, and there's others too, are one of the main things. On the federal money, as you saw, we have a ton for SUD. We don't have that much for mental health, and the money we do have is pretty restricted. So, we're looking for some flexibility there. We are going to get some funding through the most recently passed COVID stimulus package, but we're still waiting on details there. There's no funding right now for crisis or suicide prevention. Again, I think some of these things are handled through some grants we administer through some of our discretionary funding, but there's no kind of dedicated funding for this infrastructure, and it's something that I think as a state we need to work on. And I hope that this commission can be a part of that. And then just going to touch on this, and I know Matt, this is something that's very, very important to you and your members, and that's sort of those reimbursement rates are fairly low and have resulted in kind of not enough proliferation of evidence-based practices, and then also been a major cause of the workforce issues that we all know exist. So that's my very short, incomplete list of challenges. Does anybody have anything to add to that? Okay. All of these things will be talked about in greater detail in the various subgroups. I think one of our main things we were tasked with is talking about funding and talking about ways to improve funding and maybe reallocate funding. So it's going to be a focus of, I think, all the different subgroups, and hopefully that's laid out in the proposal clearly that you all read. There was a question about the upcoming budget and proposed funding cuts. I think it's probably premature to talk about that at this point, kind of given that we're only about halfway through the session. As it stands right now, there are some cuts proposed to the most previous allocation. It's something that we're monitoring and working with our stakeholders to address. I think we'll kind of cross that bridge when we get there, and then if we do end up with cuts, we'll figure out how to navigate that. Carrie, you had a question?
Yeah, I did. I just wondered, as we're going along here, would there ever be a time that it would be considered that there could be some education maybe for all of us a little bit about how the Medicaid managed care entity system works here? And because I'm thinking of recently, somebody from one of the managed care entities was talking about doing pilots about, using in lieu of services. And so that is not something that, as a commission member, I'm particularly super familiar with, but at the same time, it seemed like there was greater flexibility in thinking about how that is used, and I don't know the parameters around it. So I wondered if some education could be given to us in some way, short form, on that front.
Yeah, I think that's a great idea, and I'll confess I have no idea what that means either. So maybe Dr. Zare can add.
Yeah. And whatever your commission needs, we'll be happy to partner with the managed care entities. They have national presences, and so they can bring that expertise to Indiana. And so if you prefer sort of a one-pager, the 101, as Jay frequently has to give me a 101 on DMHA issues, or if you'd like them to come to one of your meetings, whatever would be helpful.
Yeah, absolutely. And we should certainly keep a running tally of the things that we need education on. I think that we have to be careful because, our ultimate goal is to create, actionable recommendations for the legislature. And so, to the extent that something could result from such education, then I think we would definitely consider it. But I think some of those things may be better done in other formats. But I keep bringing those things up, and I think we'll add them to the list and see if it makes sense to deal with in this format, or if it makes sense to deal with in one of the subgroups, or if it makes sense to just tackle that somewhere else. Any other questions? Okay. Well, and thanks for bearing with that very quick summary. Again, I don't want to get too into the weeds here, and I wanted to make sure we had plenty of time for Dr. Hanslick to present. I'll let her introduce herself, but I just wanted to reiterate what I've asked her to do essentially is answer the question and answer these questions through the lens of what can we do to increase access to behavioral health care in the state of Indiana, which is something I think we're all very interested in. I hope that you find this presentation as informative as I think you will. So, Dr. Hanslick.
Thank you. And I'm going to share my screen here so you'll be able to see this. Okay. Oops. Just one moment. Stop my share. Okay. I apologize. It worked when I practiced earlier. Okay. Can you see my screen?
It's blank right now. Looks like it's loading, maybe.
Okay. How about now? Can you see it?
It says you've started screen sharing, but it just, that's all it says. There's nothing popped up on it.
Goodness, of course. Okay. Sorry about that.
This is so nerve wracking. I don't know if anybody's had this, ever had to do this in our, I'm sure all of you have in our times right now. It's like one of the most nerve wracking things. So
of course,
we're all
it
right there
doesn't
with
work.
you.
Okay.
Sure.
All right. So so you don't see anything right now. Let me share my screen and then share the slideshow or make it larger. Desktop, share.
I think sometimes it just takes a while for everything to get loaded. So it just may be a lag.
Okay. Play from the start. Can you see it now by any chance?
We can see that you've started screen sharing still.
It did work before but I don't think very many people were on.
Do you want to maybe email it?
Yes.
And
Let me do that.
I can share
And then
it.
you can check. Yeah, let's do that.
Mine works, so.
For the purposes of.
We are ahead of schedule, so no worries there.
Okay, we're just time for technical difficulties. Okay. Okay, Jay, I just emailed that to you. Okay, so while maybe Jay is trying to get that set up, I appreciate your patience in trying to get this done. But again, I'm a clinical psychologist and I am approaching this presentation through the lens of being initially a solo group practice owner, then shifting to a group practice, and also several years back, I was president of Indiana Psychological Association, was able to talk with a lot of psychologists in our state, other mental health providers in our state who are non-psychologists, as well as psychologists from different parts of the country. And I found that they had some similar concerns and similar challenges. So my hope today is being able to talk through 3 points. One, what just the business management logistics are of running a practice, what the challenges are, and then what some potential solutions are to being able to solve some of the systemic problems associated with it. Okay.
It's still stuck somewhere in cyberspace, so just as soon as it's up, I'll load it. But I think.
Goodness gracious. Okay. Well, I can just kind of start talking.
Yeah, I think that's fine.
If that's okay with everybody. All right. And so a lot of what we're talking about here too is in line with some of the survey results that it seemed like was present from the last time that you had your commission meeting, including things like workforce shortage of mental health providers. Certainly, that is a multifactorial issue. But part of the pieces that contribute to that problem is financial sustainability, including non-competitive pay, low reimbursement rates, and then general issues obtaining reimbursement, certainly. So we're going to talk through those elements here too. I have a slide when you're able to see it.
I just got it. It's loading. I'm a loader right now.
Wonderful. So I'm on slide 5 when I'm looking at it myself, Jay. I have it broken down in terms of maybe what the bare bones base expenses might be for a practice owner, for a solo practice owner. Yeah, if you look down slide 5. Okay, can everyone see that? You can make it larger. Oops. Okay. Okay. And I'm using kind of where we are on the north side of Indianapolis. If you want to find an office space that's about 500 square feet, that there you're looking at costs ranging from between $600 and $800 a month. Psychologists and other mental health providers certainly have to take into account liability insurance, business insurance, maybe minimal marketing, including having a website, utilities for different cost of business. And now in the age of telehealth, when a lot of providers are conducting telehealth, they've had to get maybe more robust internet packages too, to make sure that everything is still running the way it needs to. There's billing services, but also as a mental health provider, being able to keep up with continuing education costs, additional taxes for being a self-employed individual. So on the conservative side, you're looking at, kind of based on some of these fees, $900 to $1,200 a month, or that can go upward toward $14,000 a year or so. So that's a little bit more bare bones. And this is just a solo practice. We're looking at this kind of being multiplied if you're looking at running a group practice potentially on the private sector. Additional expenses that mental health providers have to consider, things like having electronic medical record system. On the small scale, that could be from $50 a month, looking at $600 annual, but then there's all of these other fees that go on top of that. There's credit card processing fees, accounting software fees, professional services. So if you have accountants, if you have legal representation, administrative costs and billing services costs. Either providers do this themselves, which we'll talk about how that can be an issue for some folks, or they hire it out. Regardless, even if you're looking at, hiring out some of those costs, you're looking at around $1,200 a month, but that might be on the more conservative side, certainly. Additional marketing, if people are going to be doing a little bit more robust marketing on the internet, thinking about professional memberships that are also a part of a psychologist or other mental health provider's identity. And those are just some examples of local and national association approximate costs. For psychologists who provide psychological evaluation and testing services, which is going to be beyond the scope of what we're talking about, that's an additional cost that certainly is something to consider, but we won't get into that. There's also the issue, for doctoral level providers, but also for master's level providers, the cost of even paying back their own student loans for the education that they received. And that is different, certainly for every individual person's situation. But for example, in PsyD programs, people can be coming out of school, and these are 5 to 6 year programs with upwards of $200,000 to $400,000 in student loan costs in the life of the loan. There are other professions where there are similar loan costs. However, their income increases over time, and there's a little bit of a difference there too. So that's a real struggle for a lot of psychologists and other mental health providers. And then for solo practitioners in particular, if they don't have a spouse or significant other who is able to have health insurance from their respective employers, they have to find their own health insurance and get that on the exchange. Is really one of the only options that we have here. And that is an additional significant cost as well for folks. So those were some of and I should say too, that when we're looking at additional expenses, that can cost an additional $12,000, $13,000 annually. So that's an increased cost there. And of course, we know that costs of running business those aren't fixed costs, but they certainly increase over time, particularly things like leases, the cost of a lease, and every other fee. But there's also the issue of time expenses, because they're not just direct financial and money expenses, but they're the time expenses too of submitting billing, calling insurance companies to even inquire about denied claims, which is something that can occur frequently depending on the situation. But these are not quick tasks. To call an insurance provider or just to call customer service, this is something that can be a 10 to 60 minute process. which is something where if we're not, which really can be a barrier to folks. Resubmission and payment.
Hey,
So
real quick, Dr. Hanslick, I think that the slide is cut off, so I'm gonna stop sharing and have one of my team members see if they can do it without screwing it up. So don't let it interrupt your flow. But again, I apologize for the.
Okay, I'm sorry too. I don't know why it's giving us.
This is just the world we live in right now. So.
Yeah. Okay. Let me see here. The time expense is what we were talking about here. When everything's going well, there's providers can expect to receive payment from an insurance company maybe within 2 weeks if everything goes according to plan. On the upper end of things, though, there are providers who are waiting 30, 45, 60 days for payment from that date of service. They're not getting at that time of service. And so their income is delayed and quite variable. And then there are some providers and some insurance companies that require regular care reviews to ensure medical necessity. And this is something that's done over the phone or via a written letter or collecting records. And for a solo provider and in the private sector, that can also be a significant barrier to being able to both provide more care and adequate care for the patients that they're seeing.
We got it. You're good now. So
okay, wonderful. So I'm on slide 8 right now. So now I want to get into a little bit about some reimbursement examples, and I haven't outlined specific pay rates given restrictions and laws. So I want to stay within certain bounds. However, these are some examples, and this is going to be different across different payors. The codes that you see, the numbers that you see here are codes. So the 90791, that is your 60-minute intake. That's your initial intake. 90837 is a 53 and above long therapy session. 90834 is approximate 45-minute session. It's anywhere from 38 to 52 minutes. And 90847 is a couples or family therapy session that lasts 50 minutes. This may be something that many of you who are service providers or are overseeing service providers are aware of, but for those who aren't familiar with this, mental health providers can set their own rates. However, if they're in-network providers with insurers, they have to take whatever the allowable rate is, regardless of what their own rates are. So what you're seeing here, this slide, this is an example of 2 different payors, where for payor A, the initial intake session, they're getting and this is a range of kind of fees across providers in our area right now in Indianapolis. They're only getting about 72% of what their actual fees are for that intake. Only about 68% of a 55-minute session, only about 61% of that 45-minute session, and 55% of a couple session. And I don't know if any of you have sat in with a couple, but that is different. That's different work too. And so that's kind of tricky though for psychologists and mental health professionals who are providing this service. And here are some other examples for payor B, and that there are certainly ranges. So and that is static. I mean, those rates are typically not increasing. And so even as these other expenses are increasing, it is not increasing for the amount of reimbursement that they receive. And so I have some of this spelled out in terms of different income examples, potentially. Again, I don't put the specific rates in here. But we can kind of skip over that and go to now what the problems are. So that's to slide 10. So the first issue or first challenge here is, again, not something that might be new to anyone, but really the lack of standard increases at a regular rate with some payers. Even a customary cost of living increase across insurance companies is not common practice at all. There have been some payers in the area who haven't increased reimbursement rates in 10 years. And for individuals who work in other sectors or who aren't in business for themselves or in a group practice, you can expect that you might get a raise every year or two. even if it's a cost of living increase, not to mention any kind of merit increases. And even if providers, because you can certainly send a message to your provider, to the panel, but oftentimes we're met with, we are not increasing reimbursement rates at this time. Thank you for asking. And then that's the end of that conversation. Right? But when we go further and we look at continued negative impacts of what this really looks like for psychologists, I can speak for psychologists or as a psychologist, but for other mental health providers too, is that then we're faced with a decision to accept that allowable rate or discontinue the contract with the provider. I will say, even going back up to slide 8, which I forgot to mention, those percentages are for psychologists. For doctoral level providers, the rate disparity is potentially even lower for master's level providers, who also get a lower percentage of the allowable rate than doctoral level providers. So in a lot of ways, it can be even more of a detriment to master's level mental health providers. But when we go back to slide 11, there's a real risk and a higher risk of burnout for psychologists and other mental health providers because of the financial stress, truly, of the growing costs of living and conducting business without it catching up with income. Because really the only way for therapists, for mental health providers, is to increase their income, if they're specifically service providers, is to see more patients. But there's a natural cap for that. So let's pretend that 40 hours is a standard work week. There are some providers who see 40 patients in a week, but that isn't as common practice for mental health providers, because there's all of the other components of what it means to have a case, like, following up with coordination of care, writing their notes, looking up research associated with what their treatment plan is, writing a treatment plan, reviewing their cases. And so plus the emotional work it takes to be able to sit with the range of these issues that are happening for folks. So then, for psychologists and mental health professionals who look at shifting to a fee-for-service model and who aren't taking insurance at all, that can be a solution for some folks. But the issues there is that for some folks, it's really only feasible if they have certain niches, rather than being able to see kind of, other niches or specific specializations, rather than being able to just kind of see general population, mental health population. And it's only effective for some folks in certain markets and in more affluent markets. So it's really missing another subset of the population. And for some folks who go fee for service, there sometimes then is a compromise in terms of level of care, or not level of care, but even how frequently they're seen for sessions in order to kind of accommodate the increased financial burden. So then we look at the second issue. There are a number, but we're just going to focus on a couple here. The threat of clawbacks, or the imposition of inappropriate care guidelines, unfortunately, or guidelines or recommendations that are against perhaps what the clinician would dictate or would deem appropriate for their patient. So we talked about these common service codes for therapy, are the 90837 and 34, but some insurance companies begin to dictate or threaten audit or recoupment of reimbursement for providers who are giving too many 90837 sessions. When we're not quite sure if that really needs to happen. And there's a significant difference in between reimbursement rates as well for a 90834 versus a 90837. And that really, part of the issue is too, that mental health providers are frustrated about, is the clinician should dictate what is appropriate based on their patient's needs, rather than a third-party entity who really doesn't understand or know about the unique parts of the patient's presentation. We can document, we can have all of these things on paper, but it's really different when you're sitting in the room or across the video from your patient. There are also the threats of clawbacks that can really cost mental health providers thousands of dollars if documentation isn't everything, T's crossed and I's dotted. There's also a limitation in the length of time that providers can bill for services. Depending on the contract, maybe it is 3 months. So if I see a patient in July, I might not be able to bill for them in November, let's say, if there's an issue there. However, insurance companies are able to years later say, that time back in 2017, there was a problem there. And so we need to take back the thousands of dollars that we paid you over the course of that year. And that is devastating for clinicians and can really cause a lot of problems. And some clinicians say, it's not worth it. So I've collected some anecdotes, for examples of experiences from different mental health providers that wanted to remain anonymous, but just really kind of globally talk about and characterize some of the issues that we're talking about here. I wanted to read these to you. One person says, I've started coming off of a number of insurance panels due to continued low pay, interference with care recommendations, and the risk of being audited. I know some of my patients won't be able to continue therapy services with me that they need, which I feel conflicted about, but I also can't continue dealing with the stress of not being paid. Second anecdote, what insurance pays out does not increase. My spouse goes to work and gets a raise every year. Most people in other industries, their pay amount goes up every year based on either cost of living or merit, how well they're doing their job. For us, it never goes up. This is a recipe for burnout. I'm making the same amount per clinical hour as when I started in this field 10 years ago. Most people in other fields have incentives. They're working towards something, they're going to be making more, and there's potential for growth. Whereas in psych, there's none of that, which really leads to burnout because it makes you feel like you're doing the same thing day in and day out. If you're just seeing patient, there's no way to overcome that. The way to increase income is to see more patients. And even though the need is there, it's just not sustainable. And I've considered leaving the field more than once. 2 more. It does not make financial sense for me at this stage of my career to take the hit I get from insurance companies. I think I and the rest of our field deserve to be paid fairly, and doing all of the necessary tasks takes too much time. I spent an hour on the phone with insurance earlier today, which is an hour I could have been helping someone. And the last one, we tell our patients that taking care of ourselves and being filled up is vital for ensuring we're able to maintain our mental health and well-being. This is particularly true in fields where we care for others, like in the mental health field. For those who are involved with providing direct services, I frequently feel taken advantage of by insurance companies. They hold the power and they determine my income. I can ask for a raise and they say no. And my choices are to stay within the system and just take it, or come off of panels with the knowledge that many people will not be able to access therapy and psychological evaluation services they need. And I have to contend with how I feel about making those choices. So these are not easy decisions because most people go into the mental health field to help others and to sit with others who are really in pain. So it's not, I'm biased perhaps, but it's not coming from a negatively selfish place. Okay, so those are the issues, right? What do we do? What are some proposed solutions? Let's go there. Okay, there's lots of solutions, but here are just a few. Perhaps, and now this is from our side of things, right? But annual cost of living increases as standard practice could be a really positive thing if there's funding and if there's ability to do so. And that can seem like a small thing, but it goes a long way, even in terms of morale in the longer term, and that mental health providers can feel valued by the companies who are there. Also, considering different criteria for merit rate increases for eligible clinicians who meet specific criteria. These are just some examples, not exhaustive, but perhaps for number of years in the field, assuming that they've completed their continuing education and doing all of that, that might be warranted. Advanced trainings and certifications, for example, if they EMDR, trauma-focused cognitive behavioral therapy, the list goes on, but for evidence-based practice potentially, or some other kind of advanced training certifications. Board certification is another possibility. I know psychologists have that path. And that can look different for different mental health fields. But also if someone has specialized training in different populations, for example, Spanish-speaking populations, rural mental health, psychological testing, and there are lots of other things there. But those are some ways so that it's not across the board and there's a little bit of discernment about what constitutes or what providers can be shooting for as well. Second proposed solution, which can look at a couple of different things, but making incident to billing for therapy services permitted across payers. Incident to billing is where when there's a licensed provider who is overseeing a case, then unlicensed folks that they are supervising, unlicensed mental health providers, they would be able to bill for their services. Okay, there is precedent set for that. And in other states, insurance companies do reimburse for covered services. For example, for master's and doctoral interns, which are considered pre-licensed behavioral health interns and postdoctoral fellows. Some of the criteria include that the trainees have to be working toward clinical state licensure. They have to be under the clinical supervision of a fully licensed and contracted provider, and that trainee is not actually added to the group contract until they're licensed. This happens in a lot of places. For example, our neighbors to the north in Illinois, that's something that got approved a couple of years ago. This is how this helps everyone, though. There's increased access to care for patients in an affordable way. These are folks who are still providing good services and good training. They're being trained well. And there's less strain on the training programs to also find suitable training clinics, because that's another issue with the shortage of mental health providers. They can't take on more students because they're struggling with even being able to find clinical practice placement for these students, for these trainees. So more folks like myself even, and like other folks who are in practice, they would be willing to take on more trainees if there was an ability to get them patients and to have their services be reimbursed. And again, there's already precedents for this. I have the reference here that illustrates and outlines what the requirements are from Blue Cross Blue Shield of Illinois, as well as other payers across the country. So that's really something that could open things up a little bit more here. And then another proposed solution, which will be my final statement, being able to collaborate, having insurance companies and mental health associations collaborate together. For example, Indiana Psychological Association, other perhaps social work association, those sorts of things, having a liaison to discuss issues and solve problems between the associations and providers and insurance companies to address things like regular rate increases, reducing restrictions and coverage. We didn't even talk about denials and different diagnoses that aren't covered, unfortunately, in insurance. And if your primary population receives similar diagnoses, even if you wanted to, you can't accept insurance, or you can't have insurance reimburse those services because it's denied and not considered medically necessary, even though the diagnoses are in the DSM and all of that. But also for the psychological associations or the mental health associations to understand the concerns of the insurance companies and those payers, so that it's a collaborative understanding to be able to come up with creative solutions to those issues and have an increased dialogue. So those are my thoughts. And I don't know if there's time for questions, comments.
Got some time, absolutely.
Okay.
Well, again, thank you. That was terrific. Just like I expected. I definitely appreciate your focus on, I think, the solutions as well, because I think that's what we're all trying to get to. Let's open it up for questions for Maria.
Oh, looks like Carrie has a hand raised.
Hi, Maria. Hey, great presentation. You know, one of the things I was thinking, I wonder if you could comment on, well, two things. First, I'm going to say, if you take the plight of the private practitioner, right, and then you magnify that by about 1,000 or 1,500 or 3,000, then you've got the plight of larger organizations and behavioral health, right? So we all feel exactly those same things that you're talking about. But can you speak a little bit to your experience of specifically when you're talking about private practitioners, what stops them from getting involved with Medicaid? So a lot of private practitioners don't really ever enroll as Medicaid providers or HIP providers. So do you mind speaking a little bit to that?
Absolutely. And I solicited a lot of feedback from some other folks related to this issue in particular. One is an understanding or perception that it's one of the lowest paid payers. So that's a big concern. The degree and amount of paperwork that has to occur as a result of it. It's a lot easier if you know that you don't have to send in treatment plans and have treatment plan reviews, and that they're only covered for a certain amount of sessions before having to speak with somebody. So if that was gone, I think that would help a lot. And the speed with which payment is processed. It is really a deal breaker for many providers if it's uncertain when it's going to get paid, if anything is going to get paid. I know for psychologists as well who provide psychological evaluation services. I mean, if you are an in-network provider with an insurer, you can't say, no, I'm sorry, I'm only going to submit for therapy and not for psych testing services. But psychological evaluation services are limited for Medicaid in terms of how many units they will cover. And if you've seen a psych eval or any of those things, I mean, those are extremely time intensive. Let's even say on the shorter end, 6 hours of face-to-face testing, but about, you can double that for the amount of time it takes to score, interpret, and report right as well. And it's just not worth it for a lot of folks, or it doesn't feel that way, unfortunately, despite knowing that the need is there.
It's like Barb has her hand up.
Yes, thank you so much for your presentation. I am with Aspire, and we cover Hamilton County as one of our counties, and so I don't know how far you are north of Indianapolis, if you're in that area. Mm-hmm. So Hamilton County has some of I think Bowen Center indicates maybe some of the highest numbers of behavioral health providers practice in Hamilton County. Do you know what percentage? Because our experience is many of them have even actually stopped taking insurance, and they're just fee upfront, cash only, because of what you talked about, as well as high deductible individuals that really can't even access their health plan. Can you talk a little bit about that?
I can't speak to the percentages of folks, but that I think up in this area. So I'm at 91st and Meridian, so it's essentially Hamilton County right down the road. But sometimes it just becomes easier for certain folks. But it is really, as I mentioned before, it is really a decision that people toil over for a long period of time, knowing that there's going to be a large subset of folks who are just not going to be able to access their services if they do fee for service, and knowing that they can't sustain a business model, they can't sustain practice. I mean, even the anecdote, people are considering leaving the field because it just feels too stressful. And so I'm not sure if there was a specific point you were wondering about or something else I could answer about it though, Barbara.
I appreciate your answer. And I think I agree with Carrie, as we hear you as a CMHC listening to a private practitioner, whether it's independent practice or a group practice, and she says, magnify that by 1,000, we have, 500-600 staff. Not all of those are licensed staff by any means, but that overhead that you talked about, I would drool over just those expenses.
Sure. I was being very conservative also, but that was a conservative estimate. But yes, absolutely.
We experience that same thing with individuals not, we are able to give a cost of living. Thank goodness we've been able to continue to do that. But that isn't even enough. Because they're underpaid anyway. They're wanting to leave the field. I don't know how many people we have leave the field and go into retail or sales or real estate.
Yes.
So thank you very much. And thank you, Jay, for bringing her here, because you really are collaborators in this space and trying to serve people. So it's really, because people can think, oh, private practitioners, they don't really want to serve the needy, the sick, the whoever, and you do. You just can't.
Yeah, thanks, Barb. Appreciate that. I have a couple questions, and I think we have time. Our back half is not super full, I don't think so. This is a good discussion. I'm hoping you comment on kind of like the impacts you or maybe some of your colleagues have seen on some of your patients, because I think that we tend to get lost sometimes in kind of like the language of reimbursement, the language of insurance companies, the language of business. But for me, with a background as an advocate for kind of an individual patient or person going through these challenges, I open up to anybody. I'm just wondering if there's folks that have stories or thoughts about how just this lack of access. I can't tell you how many times we get, at DMHA, we get inquiries. How do I get my son help? How do I get my brother help? And the answer is you have to be like a superstar advocate sometimes and navigate really complicated systems. And even then, depending on where you are, you may be kind of out of luck. So I don't know if there's if you want to comment on the impact of the folks that are seeking help.
Yes. Yeah. I know that there are folks on my caseload who have actually really excellent insurance plans, and there are some whose deductibles are totally taken care of. They don't have a deductible, and they'll just pay. The insurance company will pay their allowable rate. If I were to come off of a particular panel, there's no way that some of these patients would be able to access services, because either they're a single income earner in the home, or even for middle SES folks, or even upper middle SES folks, not even, talking about individuals who have much less access to services and their financial pieces there. So that's one element. I know when people call our practice for services and it's someone who has a payer who we don't take, who we're not in network for, I've spoken to them personally. Our front office staff have spoken to them, and they are almost in tears, just saying, I cannot find anyone who takes my insurance. I know it's terrible insurance or whatever, however they describe it. And I just can't, where can I go? Where can I go? And depending on the payer, we don't have a lot of good answers. Sometimes we'll say, maybe try Aspire or a place that we refer to a lot, or other places where they're taking more insurances. But it's such an internal conflict. It's painful for us too, to know that they're suffering. I have folks, I have individuals who are medical providers who are looking for services for their family members and can't find a provider. And not that they're even being overly selective. I mean, like they just can't find it. So I don't know if that's a little bit about what you're asking for.
Yeah, that's great. I think the other thing I was getting at was it's really tempting to just kind of chalk this up to healthcare being complicated, right? Because we know it is, right? And we know healthcare in general is like, way too complicated and expensive, and we don't get bang for our buck, and all the things that we all know about the healthcare system. I mean, not only in our state but in our country. But what I would suggest, I think what you're getting at is it's that much worse for behavioral health as far as access and ease of navigation. You think that's a fair statement?
Absolutely. And I know, I think if it's possible, if there were any kind of even small reimbursement increases, I think that would go so much even in terms of morale for the mental health providers to say, okay, I do feel valued, perhaps, or there is something to work for. Even if they could still make, a different income if they were totally fee for service or something else.
Absolutely. And just to, it's really easy to bash insurance companies, I think. And that's, I think they're obviously an easy target. I think that we have to acknowledge that some of these deficits are structural and sort of like baked in. So, again, I definitely know that we've done a lot of insurance bashing here, but I think that the key, like you said, is to work collaboratively, right? And like understand that, we all need to, I think, figure this out, right? One of our mandates at the commission is to examine the cost of untreated mental health or mental illness in our country. And I think that this access issue is such a big part of that, right? Because why does it take so long, for folks to seek treatment? I think the studies show anywhere between 7 to 9 years of first onset to actually seeking treatment. And those costs have to be monumental, and sort of a common understanding of the importance of maybe spending a little bit of money on prevention or early access or early intervention, that sort of thing, would go a long way. And we have to speak the same language and be on the same page. There's a couple hands up here. I think our usual suspects, Carrie and Barb here.
I won't say more. I'm just real passionate about this part. Okay.
I love it.
And this is something that and maybe I'm going a little bit out on a ledge, but I'm going to say this for the BHC, which is you cannot talk about fixing behavioral health without talking about the business of care, because the business of care is what drives this. So I will simply say this: follow the money. If you follow the money, you'll know where it is that your problems are, where you have opportunities to fix things, because ultimately it does come back to what is the impact on the person. So I'm going to speak from a different perspective here. If you think about hospitals and physician care, there's hardly any physicians that are in private practice on their own, not within a physician network today, right? In behavioral health care, we don't exist in that world. Private practice, for as much as the challenges as Maria is talking about, is a very viable option, right, for individuals. And a lot of people, even within larger groups, they go on, they want some independence, right? They want to develop, they have a fascination. They can develop a reasonably, still tough, needs to be fixed, but viable option in private practice. So when she's advocating, right, for the changes at the private practice level, she has to turn to her association, right, IPA, or social workers have to turn to social work organizations to advocate on their behalf to change a system. In the meanwhile, right, then other entities are, for us with inpatient hospitals, we might be advocating through the Indiana Hospital Association, and then advocating through the Indiana Council of Community Mental Health. And behavioral health exists within FQHCs now, and they exist within general hospitals. So if you don't understand just how fragmented because behavioral health really is, it exists in so many different forms, and everybody has the same issues, but they're all having individual voices as opposed to a collective voice that addresses these problems across the board. And that's where I think you find real opportunity to develop better protocols for access. I'm sure when Maria has a client who she's seen, done an intake on, and says, hey, you know what, unfortunately, something's come up and I can't see this person because of whatever insurance, we didn't realize, I need them to get over to Aspire. Well, now that client who she's already done an intake on, right, given a diagnosis to, has to go over to Aspire, go through that same process over again as if Maria's diagnosis and assessment wasn't sufficient. Same with if a physician saw a person and said, you know what, I'm pretty sure this is major depression and I need them to be seen by so-and-so, right? You can't just accept those diagnoses and start to get care started without having to do these major in all areas, intake assessments. And the reality is that the story of the person unfolds over many, many times with them, not just that first intake. So I just want to say that there's just so much here that I think when we say complicated, it's more than complicated. The system itself has to find ways to become, I agree with you, Jay, more collaborative. And at the same time, if we don't take into account very seriously what the business of care looks like, you can't create really a viable system where access exists too. So enough said, but it's just something that I'm super passionate about, and I'll zip it.
Yeah, well said, Carrie. Kind of no margin, no mission, I think is a very accurate statement here. And follow the money, I think, is another one. Dr. Bowman, you had a question or a comment?
Thank you. Dr. Henslick, thank you very, very much for your presentation. I just want to reiterate what you said. In my experience and my trainees' experience, finding sites that will take trainees is incredibly important. They're out there and they're ready to serve. They just need a place where they can do that. And I recognize that sites will be more likely to take them if they can figure out how to be reimbursed for them. I also want to note, when it comes to access to care, we have to pay attention to our clients' various salient identities. As a client who is seeking a therapist who is an African American, for example, there are very few African American therapists, psychologists, any type of therapist in the state. If you happen to be in an area of the state where there's no one who fits your bill, it becomes increasingly difficult to figure out what to do. I've had several clients reach out to me from north central Indiana because there's no one there. Telehealth has been an incredible boon for them because they could at least see someone in another part of the state right now. So as we're also talking about access, I want to make sure we don't lose sight of how important telehealth has inadvertently become this year for people trying to find somebody somewhere who might take their insurance, who might meet some particular need that they're looking for, because that has truly become an issue. Thank you.
Yeah, absolutely. And I think that I would kind of categorize several things that have been said right now as, because the rates is the holy grail, right? That's kind of like, okay, we all know that. We know that more money is needed, no more rates are needed. But we've hit on 3, 4, 5 different things right now, I think that are, I wouldn't say easy by any means, but are not necessarily rate driven, right? We're talking about increasing access through telehealth, we're talking about the redundancies and bureaucratic redundancies of paperwork, as another example. And we're talking about kind of collaboration, right, as another example. And so I think that as the commission, I mean, we're going to make recommendations around funding, and we're going to be honest and blunt about those. But I think we also have to, and this has been hopefully a theme of the meeting so far, is we have to sort of figure out what are some of the other things, because we know that just the fact of the political and business climate, that funding recommendations are a whole other ballgame, right? And so I just want us to be cognizant of that. Katrina, do you have
I just briefly wanted to make sure that, kind of building on what Dr. Bowman had said as well, and not getting into the reimbursement discussion any further, because that's kind of Mr. Obvious, if you would, but really the rural counties, and there are 49 rural counties and over 35,000 miles of rural in Indiana. That's a lot of Hoosiers that are impacted and oftentimes can't seek that care or don't seek that care. We've seen an increase in the agriculture, community, and farmer suicide rates have increased because they just can't cope. And that's not traditionally a population that seeks mental health services because of the stigma. So I don't want to lose sight of the stigma, and I don't want to lose sight of the rural communities as well.
Yeah, absolutely. Thanks, Katrina. Jay, slide A.
I was going to say, I'm certainly not a mental health provider, be as articulate as you all about the issues, but one thing that I can plainly see is even in areas that are funded and have facilities available for mental health providers, we don't have enough. We have a large school district with 11,000 students nearly, and we've had 3 open jobs for the entire year, and we're in the greater Indianapolis area. I think a recruitment plan, which obviously hearing all of the issues surrounding the profession would certainly not be attractive to some young professional wanting to make money, but figuring out what a recruitment plan might be to attract more professionals to the business.
Yeah, absolutely. Thank you for that perspective. And I think frankly, it's really important that you're not a behavioral healthcare professional. I'm not either. And so, I've learned from all these folks, but I think that, the perspectives from that level matter a lot too. One thing I've always thought of is, or recently thought of is, how do we, and this is again, more of the softer, lower hanging fruit maybe, but how do we really just celebrate our behavioral health care providers in kind of the same way we revere first responders and because a lot of these folks are kind of on that line in the same way that other people are. And I think that, they internalize a lot of vicarious trauma, and they do it for a lot of hours and not that much money, and they don't have to be doing it, and they could be doing real estate or whatever other things Barb mentioned. We need to have a behavioral health professional day at the Pacers game or the Colts game whenever that ever happens again, or things like that may seem like kind of a smaller smaller thing, but I think that they matter, and I think that they would work towards attracting folks into those professions.
Mm-hmm. Yeah.
All right. Any other questions for Maria? We got a few. Yeah, Ray.
Thank you, Jay. And thank you, Dr. Hanslick, for your presentation. And I am a provider and a patient. And I would like to just state that I received the majority of my services through the Veterans Administration. But I also have received services in the civilian world. And one of the major aspects in mental health, at least as far as I'm concerned, is that acceptance or non-acceptance or denial from that person who probably could benefit from services. So first and foremost, as far as the dollars and cents, I'm going to say first, thank you all for what you do. Okay, because what you do, whether you believe it or not, it can be totally, beautifully beneficial. I am a person who I literally spent time of my life in a mental institution, prison, and I'm a U.S. Marine. But today I'm a business owner, I'm a homeowner, and it's because of the acceptance of my mental health condition and me working with my providers. So, hey, thank you very, very much. Please, whatever you guys do, I know Jay said about the Pacers game and the Colts game, but I'm going to just say it coming from Ray. Thank you.
Absolutely, Ray. And again, we're so glad you're here. And I can tell you that means a lot. And, any kind of service industry job, whenever you hear somebody tell you how much your work has affected them and helped them, that means more than you can imagine. So, thank you for sharing that.
Mm-hmm.
All right. Any other questions for Dr. Hanslick, or do you have any parting words of wisdom, Dr. Hanslick? And any ideas for how we can move this ball forward?
I think even as Carrie mentioned it a little bit, and perhaps I'm biased in working with the Indiana Psychological Association, but I really think working with the mental health associations is a really powerful and useful partner, because they have a nice pulse on what is happening with the service providers in the respective professions. So I would really advocate for that as well. And that can be a nice mechanism.
I just was talking today with, yesterday with some MCEs about doing a collaboration meeting in our next quarterly meeting to see how we can get to some of these process measures that DMHA has been chatting about. So we're taking that to heart, Doctor, and we're going to work towards it.
Sounds great.
Great. I believe I missed Barb. I'm sorry. I think you wanted to make another comment. Is that right?
Oh, I know. Sorry. Just real quick, because Jay, you guys, the DMHA workforce meeting where you brought in Hannah, remind me of Dr. Hannah's last name from Bowen Center.
Maxie.
Yes, yes. The information. So I think it's good that this group hears it. And Dr. Hanslick, I think you would probably be interested to hear this. Of the licensed clinical social workers in the state right now, 20% of them work in CMHCs. Still a higher number work in private practice. And then for psychologists like yourself, HSPPs, only 11% work in CMHCs, and the larger percent is in private practice. So private practice actually represents a higher number of practitioners than the CMHCs. I think that is profound for this group to understand. And I really thank Jay and Rachel and DMHA staff for the workforce group they've put together to start looking at it.
Katrina, and then I think we'll move on.
I'll be very quick, I promise. I just wanted to say that I think the collaborative efforts are our best means of moving change forward. So the National Association of Social Workers Indiana chapter, along with the Psychological Association, we're better together, we're stronger together, and Indiana Rural Health as well. So if anyone would like to reach out, I'm a part of 2 of those and would be happy to coordinate.
Yeah. And my contact information is at the beginning of the slide as well. So if anyone has any other ideas afterwards, or if I can be useful or of assistance, you can let me know.
All right. Well, again, thank you so much, Maria, for taking the time to come chat with us. I imagine we'll recruit you to come talk to one of our work groups, or maybe another meeting again in the future.
I'd be happy to.
Yeah. So again, you feel free to hang around, or you can go on your way, whatever you want.
Okay.
So kind of switching gears here now after, and I think it actually flows pretty nicely from that conversation, because one of my takeaways from that conversation was just how freaking complex and complicated this whole thing is, right? I mean, we Maria did a heroic job to distill whatever she had to distill down to, the 25, 30 minutes that she did. And I mean, definitely got the sense that she was just scratching the surface and only covering a very small part of what we have to cover in one area that we have to cover. And so, to that end, kind of getting this is the last kind of half hour of our meeting is to talk about what future meetings look like, which is, a painful but necessary part of these sorts of things. So Bethany, do you want to share the proposal? I hope you all got a chance to review it for the subgroups. Are we going to share it on the screen?
Yes, I am working on getting it pulled up right now.
Okay, perfect. Sorry. Thank you. I appreciate that. I don't want to do that again because I screwed up so bad last time. So, just to give you a little bit of how the sausage is made kind of background. We spent the last couple months after the last meeting taking a look at the surveys that you all filled out, talking to some commission members, including and also other stakeholders, including people that were involved in the kind of creation of the Behavioral Health Commission statute. And our real challenge, and the folks that were involved with the creation, I think admitted, frankly, or not admitted, but I think we're open with the fact that the statute that authorized our creation kind of grew beyond what they initially had intended. And as a result, I mean, we have a very broad, expansive mandate, which is great because we get a chance to sink our teeth into a whole lot of other things. but we also have a whole lot of ground to cover if we are in fact going to produce anything of consequence or anything meaningful, moving down the road. And it's always important to remember what our end goal is, which is, is to create meaningful, specific, tangible, actionable suggestions for the legislature and executive branch of the Indiana government about how we can, move the needle on improving behavioral health. And so, we took the statute, we took the surveys, we took the conversations, and we came up with what we think is one way to do it, right? And I mean, there's a million different ways to do something like this. There's not really a right or a wrong. I think, we kind of sliced and diced the statute up a little bit, and this is kind of what we came up with. So we like to go over this proposal, see if there's any kind of questions or comments, and we can kind of modify and edit it on the fly if we need to. I think substantive edits are going to be difficult. So if it turns out there's a rebellion brewing, we probably need to go ahead and go back to the drawing board and schedule another meeting. But if everybody's sort of in line with the general outline, then I think we'd like to vote on the structure and the descriptions if we can. So before we get started, the first thing I wanted to talk about, and Carrie, maybe you want to go into what you were thinking. So can you scroll down to the equity and workforce group? We have a modification that was suggested by Dr. Cadwell, which I think is the right one. And so one other thing, I think maybe will you scroll down to the very bottom? Sorry. So we divided up into, not only did we divide up into work groups, but we also decided to create what we're calling kind of like, areas of assessment. And this way we're able to cover all we need to cover by the statute. So so not only do we have substantive areas, but we have kind of areas that each group will have to take a look at, and then also could take a look at. Now scroll up to the equity and workforce. So the suggestion from Dr. Cadwell was this group number 4, equity and workforce, was to make this just workforce and then make equity another one of those areas of inquiry. So each group will have to take a look at issues of equity within these various areas of various subgroup areas. And to me and to us, that seemed like it made sense. We would, I think, the proposal that we're working on, if you can just imagine, workforce it's just workforce, and then equity is one of the areas of inquiry. So that's an edit we'll make and put up on the commission website when we get a chance. So now I guess we'll kind of start at the beginning, which is a good place to start.
And Jay, as they're scrolling, I just wanted to highlight with the equity piece, we will be giving some guidance around how to make sure that we are still being intentional. I know a lot of times when there are work groups or evaluations, it can kind of turn into a check mark, like, are we equitable or not? Yes or no. And rather than that sort of response, we want to be intentional about having it be open-ended and focused on gaps and areas for improvement. So we would just really want to make sure that that it's understood that our shift from having it be its own column is actually to enhance the focus on it. Make sure that every single one of the columns is really considering that. So I just wanted to make sure that was really, really clear for the people here on the meeting.
Yeah, thanks, Rachel. It's a really good point. And just pointing out that consideration of equity is not only really important for all the reasons that we know and have talked about, but it's actually in the statute as well. So we have a mandate to examine through that lens. So just kind of going through the work groups really quickly, and we can feel free to, if anybody has any questions or thoughts, feel free to open it up. But so the first group is children and families. This is a very important area, and these particular pieces, again, an important thing to remember is two important things to remember. Number one, these work groups will not be working in silos. We plan on staffing the work groups within DMHA to minimize the siloing. And if there's some redundancies, that's okay. Ultimately, we'll work together to compile recommendations into kind of coherent, cohesive group. But not only will they not work in silos from each other, there's also other groups that are doing these sorts of things within state government. And so we need to make sure that we coordinate and interface with them and you know, see if it makes sense to either divide and conquer or kind of reinforce and support these work groups. And so you can kind of take a look at what we think this group should look at, but and then also the point that we should collaborate with the mental health working group of the Children's Commission. Any questions on children and families or thoughts about what the charge is?
Hey Jay, this is Christy Berger from DOE. I know you put on there to work with the CISC group, so I lead that, the Education Outcomes Task Force. Do we think it could be the same group, or you're wanting to have two separate groups, or could we just add some people from this commission if interested to the group for the CISC?
Yeah, I'm not exactly. I don't know. I don't really know, to be honest.
Okay.
You know, because I mean, we have a mandate to create a report that includes things that cover children and families, and there may be things that the CISC group is not working on. I think, frankly, the fact that you are working there and there's a couple other people at DMHA that are on the group that I think we'll go ahead and divide into a separate group here because we're with BHC members, but you know, it may make sense for that group to only meet once and merge. It may make sense to do its own thing. I think that we're going to just kind of take this you know, one step at a time and not necessarily you know, try to predict how it's going to go. So but yeah, I think that having you on both is really valuable, and I know Bethany Eckler from DMHA and Cirilla and Leslie from DMHA are involved with CISC, and so we'll make sure that's not redundant, but there may be things that that CISC wanted to cover but didn't get to that we may want to cover separately.
And I'll just throw in, Jay, as you kind of touched on already, the name of the game here with these different subcommittees is to avoid duplication of effort, as we know other work in these areas is occurring elsewhere in a lot of instances. So that example, I think, is a perfect one where we can say, hey, we already know this other group is working on XYZ part of this. Let's loop them in. Let's connect with them. Let's see what they're doing that we can either enhance, add weight to, or work off of. So we do want to be really intentional that we're not just working in parallel with other groups that already exist. The Behavioral Health Commission, I think, is the starting point and the core subgroup, but whomever we need to consult with and pull in to get these tasks done, the subgroup should feel very empowered to do so.
Yeah, and just to piggyback off that, I think the subgroups should feel empowered to either, you know, to adopt or amplify or build on or by contrast, you know, do an examination on their own, depending on what makes sense. And so, and you know, the DMHA staff will be here to kind of make sure that there's coordination with all this. That's a good question, Christy. Thank you. Any other questions on the children and families? All right, moving on to number 2, and this is, you know, like it says, I think that, you know, the many inquiries into these problems, I think necessarily focus on like treatment and outcomes that have already kind of been identified and people that are already using the system. And this is a little bit of the different of a charge, and this is the kind of overall mental health and well-being of Hoosiers. To me, this is especially poignant in light of the COVID-19 pandemic, where we're seeing kind of unprecedented amounts of overall reductions in mental health and well-being as a result of the disruption to our lives. And so to me, this group could not be more timely. But again, any questions or thoughts on this group? Okay. The next group, and this is another area where it's pretty likely that this group will kind of adopt and or amplify or support the work that's already being done. We have a pretty robust suicide prevention and task force that has actually adopted crisis as well as one of their charges. But this is, again, this is an area that was all over the statute, so we wanted to make sure that this was included. you know, I think that probably we'll see what ends up happening, and we don't want to put the cart before the horse, but we'll probably, this may be one of those things, like Christy said, which may just be kind of merged or subsumed into a larger initiative. But you know, we wanted to make sure it was clear. Any questions? All right, moving on. So this next group, again, remember it's workforce, and so, you know, we're gonna take the equity and move it down to kind of the areas to look at. Again, with the caveats that Rachel said about how important this is, number one, and number two, that we're gonna hopefully provide some pretty substantial guidance to make sure that the equity is treated with the kind of seriousness and intentionality that we all know it deserves. But the workforce, I think we've talked about workforce issues, you know, and so not only, and Carrie's other suggestion was not only examine the ways to increase the number of clinicians, but how to better utilize the clinicians or the non-clinician workforce that we have. But, you know, and anything that's related to workforce. Any questions or thoughts there? Yeah, like Bethany said, if you have comments on the go, or if you think of a comment afterwards, go ahead and send them to the chat, and the work group will capture them and make sure that they're addressed. All right, scroll down to number 5. This is the one we had the hardest time naming. I will be honest, because, you know, we didn't want to use the phrase continuum of care, just because that has a very specific connotation in our administrative code as it relates to the CMHCs. But what this is about examining the system kind of through the eyes of an individual's journey through that system, an individual and family's journey through that system. So identify gaps and barriers and opportunities, ways to integrate, ways to coordinate, again, with the end goal, which is a direct quote from one of the creators of the commission, which is a user-friendly system that significantly improves outcomes by providing rapid access to high quality prevention, early intervention, and treatment as early as possible in disease progression. So this is a pretty big charge and task. I mean, you could maybe argue that this is probably an entire commission on its own, but at the same time, I think that it's only one of a bunch of different things that we have to take a look at. So looks like Barb, you have your hand raised.
Yeah, I have a question.
Sure.
Define the behavioral health system. Is it what we were indicating earlier? Carrie, I think, said it really well. You know, behavioral health is in FQs and primary care and hospitals and schools and CMHCs and private practitioners. What's the behavioral health system?
Yes, is the answer to that.
Yes.
I think it's all those things that you mentioned. I mean, yeah, that's, again, this is not the public sector commission. This is not the Medicaid commission. This is the and again, that's partly why this is such a challenge, right? Is because, like you said, I mean, there's so many different stakeholders, and we touch on everything and everywhere. And so, I mean, again, this is the group. This is a group that will probably do the most, frankly, kind of, you know, from the ground up work, because this is not being done anywhere. And so, at least as far as I know, I think maybe it was done in the past, I think, but at various points, but it's not being done right now and hasn't been done in a while. So that's a good question. And I think that, again, we're just defining these as broadly, and each subgroup can kind of winnow or whittle it down as they meet. Okay, and the last one, it just, you know, to be honest, was we were on the fence whether this should be an area to look at, or an area or a specific working group. You know, we ended up going with a specific working group, just because, partly because of, frankly, the folks we have on the commission, and some of their, I think, pretty awesome insight, but also because this is, I mean, we know, unfortunately, that one of the most important linkages and most significant linkages that we have in our system is between criminal justice and mental health / substance use disorder. And so, you know, this group will be tasked with examining those linkages and kind of making recommendations. Now, there are groups working on it, and so we got to make sure we coordinate with JRAC, which I'm on, and I think a couple other there's a couple other cross pollinating people there. But again, this is one of those things where, to me, you can't examine the system as a whole without including criminal justice in that examination. Yes, Barb.
Sorry, that was because I think sorry, I don't want to lower my hand. I really appreciate this area, and but I'm sensitive to that first sentence, how it reads. So you kind of solicited maybe some editing.
Yeah.
So we'd have to wordsmith, but this would be my only concern about this. The premise is the behavioral health system has failed to prevent or treat people with mental illness. And I'm not really sure it's just the mental health system. I'd rather say that people in the criminal justice system, for many reasons, prevention and treatment hasn't been successsul for them, and not necessarily say it was the behavioral health system.
So the cause, and I'm totally fine with it. I mean, I think that, I don't know.
Well, so 988 has shown, we have a law enforcement system that is the 911 is what ends up responding to psychiatric crises. Was that a behavioral health system ineffectiveness?
Right.
So I just would want to acknowledge that people in the criminal justice system who have mental illness and addictions are not getting their needs met well. And so what do we need to do about that? That might be a poor way of saying it.
I think you're dead on, Barb. I like what you said. And I think we need to consider that, Medicaid doesn't cover outpatient services in the jail. And there's payer source issues associated with this. Beyond that, we're not treating them effectively. If we have the opportunity to treat them effectively, we will, which will help move people away from the criminal justice system.
So what I would say that, Matt, is that in this definition, to me, and then I'm open to changing this, Medicaid is part of the behavioral health system in the broad way we're describing it, and so are schools, and I can certainly, if this is causing discomfort, we can certainly just take the causal link out of the language. That's totally fine.
So one of my metaphors is, would we say the cardiologists are not effectively preventing people from having heart disease? That's I wouldn't say that.
But you might say the public health system as a whole, including, for example, nutrition education or kind of that sort of thing is, and that includes, for example, the cardiologists are the acute side of it. But you could take a look at what are the schools doing, what are the social determinant issues, which we haven't even really touched on. That's more of an area.
Yeah.
So that's why
people who live in the wrong zip code.
Yeah.
Have these problems.
So to me, that expansive definition of behavioral health system, doesn't necessarily isn't an indictment of any one person. It's or organization or even one group of organizations. It's just kind of like a catch-all for the things we have to examine. So you could just say system, and that might make you happier, but it's also kind of vague. So Steve,
I will say that it also, oh, sorry, Steve. I think also it's, there's a lot of reasons that the behavioral health system isn't, getting these things done. And it's not necessarily because of the drivers of the behavioral health system, like the people and the agencies. There's all sorts of things around funding, structure, reimbursement. I mean, there's a lot of play there for sure. So I think just to echo what Jay was saying, definitely not an indictment or a finger point, but we can change the language if it feels like that. Steve, sorry about that.
No, that's all right. And maybe I don't know where you're going to go with this, but I almost wonder if after you figure out who's on the various groups, it seems to me the first thing each group might do is look at the mission statement and basically rewrite what they want to focus on as a mission statement, vision statement. They'd probably be more specific and detailed than the starting point that you're going to give us. I don't know. Is that wrong? And
I 100% agree with that.
Okay. And so like we could wordsmith these till we're blue in the face, but I think we could just wait and let the committees do it. That'd be my thought.
Yep, I 100% agree. And so if, I think this was just so, yeah, absolutely. None of this is written in stone. It's just, it exists in a very easily editable document. So, as each group comes up with their, initial report, one of the things they have to do, I think, is define a lot of these terms for themselves. So. All right, thank you. That's a good discussion. I appreciate that. And I think that, again, always be mindful that none of us are here looking to indict any one system or group of people. But we're all here, we know that we all collectively are failing in some ways, and we're here to make those things better.
Jay, if I just may for a quick second, I mean, we've seen the revolving door history since the Community Mental Health Center Acts of 63 and 64. We can show trend data for decades. And I think the most important thing for this commission is that we don't blame the patients, whether they're in hospitals or community mental health centers or criminal justice systems, because all Hoosiers have value. And they have value to their communities. And I'm extremely passionate about that. So I want to make sure we never lose sight of that and make it their fault that they're in any system. Sorry, soapbox moment.
Well, no, great points. I mean, that goes to the idea in the SUD world where, people, the stigmatizing language, you would never use that in any other kind of medical space. And so that's absolutely a good point. Scroll down, Bethany, to the kind of the last piece of it. And so this again, this is a framework that can be modified and changed and adjusted by each group kind of to their heart's content. With the only thing that we have to look at because of the mandates of the statute are sort of the funding, rapid access to quality care, and system design, and then we're adding equity to that. And then everything else, I think, is up for debate. And this is not an exhaustive list. There's a million other things we can take a look at, and I think we'll kind of let it to each group kind of to come up with what it is that they want. So, because we need to get to voting, I'm going to open it up for just general discussion, with the caveat. I think remember Steve McCaffrey's comment that each group will have a lot of autonomy to not only perform their tasks like it says here, but also define their mission and define their own terms. So let's keep that in mind. But I'll open it up now for discussion on kind of the document and also the overall structure. And any discussions or anything on that.
The only thing I had, Jay, is, and I think maybe you alluded to this at the start of your comments, but, aligning this with exactly what the statute expectation is with respect to the reports and the analysis, and will the charge of the groups mirror sort of the steps that were outlined in the statute, and how will that all get kind of wrapped up?
Yeah, absolutely. So yeah, the statute was definitely the basis of this. One of the areas of the one of the main things with the statute we felt like we had to modify was one of the areas of the statute was assessment and inventory, and for us that was more of a step, right, as opposed to an error. Like, so that's going to be kind of the first thing that these groups will do, is perform that assessment and inventory of everything, but everything else sort of flows directly from the statute, if that makes sense. That was the kind of big breakthrough we had, which I think unlocked the whole group, right? But everything else does flow from the statute. And then ultimately, I think it's really important that ultimately we will collectively work together, and the DMHA team will drive that bus to make sure that our ultimate products, whether we have one or two, will directly correlate with all our requirements. So,
I don't know if this is like overly anal and technical, but I almost wonder if, since it did flow from the statute, if there'd be logic and value in almost a footnote after each one of the sections of the statute that it relates to, with the idea that, we're not going off the rails here. You can actually look back to what the statute says. We are addressing the statute as requested by the legislature. And then the groups, when they get to a place where they're not sure where they're supposed to go, they could look back at those sections and double check and make sure they're on par with where they're supposed to be. Just a thought.
Yeah, I think that's probably a really good thing for the group when they're coming up with their kind of revised mission, to also reference the statute as well. I definitely would like to vote on this today. So so it might be a bridge too far to expect really quick site checking on the behalf of our DMHA staff. But I think absolutely, I think that everything we do needs to be tied to that, because otherwise we sort of start to lose credibility in terms of, well, they're overreaching. So.
Yeah, I mean, and I don't know, and maybe it's being too lawyerly, but if one were to make a motion to support the document, you could in the motion mention that we would amend it to include the code citations and how we plan to rework the equity provision.
Great.
And if that was a motion from Mr. McCaffrey, Relay, I will second it.
I don't, again, talk about getting lawyerly. I believe he said if one was two, not I am making.
Yeah.
How about this? I'll make that as a motion and Ray can second it for purposes of discussion. How about that?
All right. So we have a motion and we have a second. Any discussion on Steve's motion? Okay, so to restate the motion is to accept this framework for the next phase of the Behavioral Health Commission with two additions. One is that we're removing equity from the equity and workforce group and making equity into one of the mandatory areas of inquiry. And the second piece of it is we're going to add code citations to the work groups to make sure that it corresponds with the code. Okay, so we have a motion and a second. So all in favor of the motion, please say aye.
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 Anyone opposed? All right, the motion carries. All right, so finally, the last thing we have to talk about and not vote on, but just talk about is how we're going to actually divide up into groups. Bethany, you can go ahead and stop sharing. I think we're good. So, I mean, really simply, we kicked around different ways to do this. We definitely didn't want to do it in real time on Zoom in front of the whole state, because that, reminds me of being on the playground and, we're picking captains and it's a really awkward situation. So I don't want to get into that. So instead, we're gonna basically solicit your preferences by email. So take a look for that. We're gonna try to accommodate people, and we're certainly open to folks volunteering to be on more than one. Please indicate if you're interested in being on more than one. But to keep in mind that we expect these to be working groups and everything that entails. So, be mindful of your own schedule when you're doing that. We do ask everybody commit to serving on at least one group. And we'll take a look at that, and we'll hopefully get those assignments out very soon, and then work with those different groups to schedule meetings. Now, from a public access standpoint, I do believe every single one of those meetings has to be public. So that's something we'll take care of and figure out. But it's just another wrinkle that we have to work on. DMHA team, Bethany, anybody else? Did I cover that, or is there anything additional?
I think, this is Bethany. I would just add that the work group will be sending out a survey link essentially to get your preferences. So you don't have to kind of send those our way. We will elicit those from you.
Yeah. And I have to just again thank so much the DMHA group that's been working on this behind the scenes. Bethany, Elaine, Kelsey, Jocelyn, Amy, and Alexis. this has been just a ton of work, on top of their day jobs for this commission. And everything that you've seen and that we've done is 100% testament to them. So, thank you all. It's, definitely couldn't do it without you. Barb, do you want to say something? No? You sure? All right. Okay. Does anybody have?
I'll wait for it.
Okay. Does anybody have any other comments or questions or thoughts? Sheriff Nielsen, you got anything? I know it's your background, so
I'm good.
Good. All right. Sounds good. Okay, so yeah, everything's gonna be posted to the Behavioral Health Commission website. If you have any other follow-ups, we're always here, either for the public. Actually, Bethany, do you want to share the email address one more time before we adjourn? Feel free to shoot us an email or individually or to the commission website. And we look forward to these work groups getting up and running, and then just kind of be looking out for that survey. Not sure when we're going to gather again. It probably depends on how the work groups are going, but we'll just kind of see. All right, with that, happy spring, hopefully, and the meeting of the Behavioral Health Commission is adjourned.
Bye, everyone.
Thank you.
Goodbye.